Welcome to Dr. Mercola's Cellular Wisdom. Stay informed with quick, easy-to-listen summaries of our latest articles, perfect for when you're on the go. No reading required. Subscribe for free at Mercola.com for the latest health insights.
What if the rule you've trusted for years, counting every sip to protect your heart, turned out to bring you no benefit and a lot of needless misery? Hello, and welcome to Dr. Mercola's Cellular Wisdom. I'm Ethan Foster, and today you'll hear why blanket fluid limits for chronic heart failure don't hold up under real-world scrutiny and what a smarter, more comfortable approach looks like for you.
I'm Alara Sky. In this episode, you'll learn how the largest clinical trial on this topic shattered old assumptions, why constant thirst spikes your stress hormones, and how balancing sodium with potassium lets your kidneys control fluid naturally. By the end, you'll know practical steps to hydrate wisely without the fear that every extra glass somehow endangers your health.
Let's start with the numbers. Roughly 6.5 million Americans, and about 26 million people worldwide, live with heart failure. You may recognize the daily realities: shortness of breath when you climb stairs, swelling in your ankles, and fatigue that makes errands feel like marathons. For decades, the standard advice has been simple: limit fluids to roughly 1,500 milliliters, or 6 cups per day.
That advice seemed logical on the surface. If excess fluid backs up in your lungs or legs, surely drinking less would ease congestion. But bodies aren't plumbing systems. You're already using diuretics and newer medicines like SGLT2 inhibitors that nudge your kidneys to shed extra water and sodium. Adding harsh intake limits on top of those drugs can tip you toward dehydration without improving outcomes.
Enter the Fresh Up trial: fluid restriction in heart failure versus liberal fluid uptake, presented at the 2025 American College of Cardiology meeting. Researchers enrolled 504 adults with stable, mild heart failure across 7 Dutch clinics. Half were asked to stick to that classic 1,500 milliliter cap. The other half could drink as desired. They tracked symptoms, hospitalizations, kidney function, and a quality-of-life score called the Kansas City Cardiomyopathy Questionnaire.
The headline finding: no advantage at all for the restricted group. Whether participants stuck rigidly to 6 cups or comfortably exceeded it, hospitalization rates, kidney injuries, and survival were identical. Yet thirst distress soared among those forced to ration each sip. When you feel parched all day, your body releases vasopressin and adrenaline, hormones that raise blood pressure and make your heart work harder, not easier.
How much more did the liberal group actually drink? On average, just 276 milliliters extra, under 10 ounces, or a small water bottle. Yet that modest freedom meaningfully improved comfort scores. Some participants topped 2 liters daily, with zero increase in adverse events. That demolishes the fear that every extra glass pushes you toward a crisis.
It also exposes a hidden danger, combining strict water limits with severe salt cuts. Many of you have been told to slash sodium while restricting fluids, but that duet can drive sodium so low you experience confusion, muscle cramps, or even seizures. Meanwhile, getting enough potassium, think potatoes, squash, avocado, or coconut water, helps your kidneys shuttle fluid where it belongs and prevents harmful buildup.
The big question is why doctors clung to this rule. Earlier guidance rested on small, uncontrolled studies from an era before today's medications. Even major societies noted the evidence was low quality, but the recommendation persisted because no one had tested it rigorously until now. Patients themselves pushed researchers to prove whether the hardship was worth it.
Those patients understood the day-to-day cost. You're thirsty at dinner but scared to join friends for an extra glass of sparkling water. You wake at night craving a sip, yet worry it might land you back in the hospital. That constant self-policing erodes quality of life, and the new data say it's unnecessary for those with stable, well-managed disease.
Let's translate findings into practical guidance. First, if your cardiologist says your heart failure is stable and you're on the right medications, you can safely drink when you're thirsty. Instead of counting cups, track daily weight, ankle circumference, and ring tightness. A sudden 2-pound overnight gain or puffier feet signals fluid retention more reliably than a fluid log.
Second, pay attention to how you feel after hydrating. If a glass of water leaves you breathing easier and less fatigued, that's your body thanking you. If you notice swelling the next morning, adjust intake or discuss your diuretic dose. You're the best sensor system you have. Lab tests back up what your daily experience already tells you.
Third, support electrolyte balance. Rather than fear all salt, aim for a moderate quality source like Himalayan or sea salt, paired with potassium-rich foods. Potassium counterbalances sodium's fluid holding effect, helping your kidneys remove excess water without extreme measures. Unless you've been warned about high potassium, a baked potato with the skin or a serving of cooked spinach can be a fluid friend, not a foe.
Fourth, be aware of dehydration's ripple effects. When vasopressin surges, it narrows blood vessels and drives blood pressure higher. Adrenaline ramps up heart rate, leaving you jittery. Long-term, that fight-or-flight state strains the very organ you're trying to protect. Comfortably hydrated tissues reduce these hormonal alarms and keep your circulation calmer.
Fifth, rebuild trust in your own judgment. The Fresh Up authors called their work a patient-driven study, precisely because you challenge clinicians to prove the rule. That spirit matters. When your daily experience conflicts with advice, voice it. Medicine improves when patients push for evidence that aligns with lived reality and personal comfort.
You might wonder if any situation still warrants restriction. Yes, if your heart failure suddenly worsens, your ejection fraction plummets, or you're hospitalized for acute congestion. Temporary limits can help until medications regain control. But that's an exception, handled under close supervision, not a lifelong blanket command for every stable patient.
Let's walk through a sample clinic visit using these insights. Imagine your physician asks about thirst, daily weight, and swelling rather than cup counts. Together, you set a range, perhaps 1.8 to 2.2 liters. Then adjust based on morning weight and how your shoes fit. If you exceed the high end and feel fine, no panic. If you're below the low end and feel dizzy, you drink. It's that flexible.
This person-centered model also improves mental health. Research shows restrictive regimens increase anxiety and reduce adherence to other therapies. When you aren't battling relentless thirst, you sleep better, take drugs on schedule, and engage in light activity. Behaviors tied directly to better outcomes. Comfort isn't a luxury, it's therapeutic.
Summing up the science, strict fluid caps failed to improve survival, hospitalization, or kidney outcomes in the largest trial to date. They did worsen thirst and stress physiology. Modern heart failure treatment should guide fluids by symptoms, daily metrics, and medication profile, not a universal 6-cup ceiling.
That leads to today's challenge. Choose one moment, maybe lunchtime or your afternoon break, when you usually ignore thirst out of habit. Instead, drink until you feel comfortably hydrated. Then note changes in energy, breathing, or mood over the next few hours. Tomorrow, repeat and compare. Your body's feedback will become the most trustworthy gauge of what's right for you.
Thanks for joining us on today's episode of Dr. Mercola's Cellular Wisdom. We'll see you on the next episode.
Thanks for watching. Subscribe now and click the notification bell so you never miss an update. See you in the next video.